Hi everyone, and welcome back to our next episode of Rewalk's Topics in Neuro Rehabilitation webcast. I'm Jill Butler, and today we'll be talking to one of the therapists that we met while working on the Restore clinical trial for our FDA clearance. Kristen is a physical therapist and certified neurologic clinical specialist working in the Max Nader Center for Rehabilitation Technologies and Outcomes Research in the Shirley Ryan Ability Lab. She has extensive experience using lower extremity robotics, both in research and clinical practice. And today's talk will expand on the framework that Matt introduced in last week's talk by providing some examples of how she has applied that framework into her clinical practice. Hi, Kristen. It's great to talk with you today.
Thanks so much for the introduction, Neil. All right, so we are going to be talking about the incorporation of exoskeletons and Exo-Suits into clinical practice through a couple of different case examples. And through that, we're going to be using the framework that my colleague Matt talked about last week. And kind of using this as our working framework. And so we're going to be using two different case examples today, as well as integrating high-intensity gait training into these case examples as well. So for individuals with chronic CNS injuries, we now have guidelines for best practice in terms of improving locomotor function, in terms of improving walking endurance and walking speed. That was just published earlier this year, and that evaluated the evidence from basically 1995 through December of 2016. And that was a clinical practice guideline that was published. And it basically says we should be performing moderate to high intensity walking training. It's a fairly strong level evidence, and that's our first action statement. But if we get down in the CPG, we get this, okay, maybe we should scratch our head. What are we doing with this? It says robotic assisted walking training following this should not be performed in terms of exoskeletal robotics on a treadmill. And really, if you read further into this, they're really looking at devices that have been studied previously, like the Locomed or end effector devices. They're not talking about the exoskeletons that we're going to be talking about today, because again, the evidence that they've assessed is only through December of 2016. A lot of these devices weren't even on the market at that time. They do make a qualifying statement that perhaps in the CPG, if someone is non-ambulatory or needs unable to ambulate without the robotic device, then perhaps this statement would be different. But again, this I think just needs a big asterisk for the application of exoskeletons in practice. But I think the first statement is certainly something that we can utilize with our exoskeletons, and thinking about how do we do that in clinical practice is important. So what do they mean? Well, the American Heart Association comes out and says, okay, we should be shooting for 55 to 80% of heart rate max in terms of intensity. But if really you look at some of these papers that have been compiled into the evidence, moderate to high intensity gait training is really kind of even higher than that, in the kind of 70 to 85% of heart rate max. And so that's what we're looking at in terms of intensity of training and getting our patients to that threshold and kind of that range. All right. So how do we incorporate both the principles of the CPG of high intensity gait training and using exoskeletons? I think there's kind of potentially a discrepancy or a disparity there. And I think really we have to start in that upper left-hand side in that blue area with each of our patients. And so we have to think about like those individual deficits. Do they have medical precautions that we need to be thinking about first of all? That would preclude you from even pushing into that higher intensity zone? Or are you more concerned about a presentation pattern that you need to address first, such as a lateral pulsion? And then, all of these reasons are completely valid that you would not push into a higher intensity zone. And I think, the biggest thing here is just being thoughtful with how they present and really setting your objectives and your goals before you even start to utilize a technology. And then from there, once you've identified those things, then you can think about, okay, what is the best way and what best technologies do I have at hand that would suit that patient the best. And so based on that, then you would intervene and then at the very end reflect. And so we'll talk through this with our 2 case examples. Our first one here is, I'd like to highlight, is a 38-year-old male who has a C for traumatic spinal cord injury after a diving accident. And actually his initial ASIA exam was a C4 and ASIA C. And amongst his therapy, he began was high intensity gait training on the treadmill and overground training while in inpatient rehab with, again, that guideline of 70 to 80%, 85% of his heart rate max. And I want you to kind of look here at the graph on the left-hand side of the screen, and we were using the 6-minute walk test on a weekly basis, assessing his progress. And as you can see, is the blue is the distance that he walked in the 6 minutes, and the green is the level of assistance that he walked with, according to the FIM. And as you can see, there's a pretty much an upward trajectory each week. But then maybe around week 5 or 6, things start to potentially plateau. And that's when his gait therapist approached me with this video and said, you know, do you think he might benefit from it? You know, I'm starting to be concerned that his posture, his weight positioning, his coordination and control might be limiting some of his additional progress. And, you know, would an exoskeleton be helpful, or is he too advanced at this point? And he has trouble not only in the forwards direction, but you'll see here in a second, the backwards direction as well. And so, if we use that framework, identifying the deficits, he has a forward trunk posture, he certainly has impaired weight positioning, and he has a stepping asymmetry and discoordination with a step. He's not getting an equal step length, he's not consistently getting steps through, and really you can see he doesn't have great control. He's kind of all over the place, both in the forwards direction as well as backwards. And so in terms of objectives, this is certainly not specific here enough if I was actually setting goals, but just kind of being broad and overview, we need to improve his independence with walking, improving his walking endurance. We're measuring his 6-minute walk test distance on a weekly basis, and improving his balance and control, but using objective measures certainly, but kind of an overarching objective there. So what technology would we utilize here? You know, I think based on his deficits, I thought we would need to utilize a 2-joint device, just because I thought we needed a little bit more postural support for him. And so I chose to utilize Exo because of the capability that I felt like he needed with the postural support, as well as the ability to progress from a fixed limb trajectory, kind of guiding his steps and showing where he needed his weight to be, as well as then dropping down the assistance and adding in actually resistance through the swing phase, and then the capability to go even into the backwards direction, which he was certainly having difficulty with. As he progressed, you can see we progressed from using the rolling walker to using handheld assist to try and continue that carryover of his postural improvements, as well as his ability to maintain his weight positioning in the device. So this is actually the same graph that I showed before in terms of the y-axis and the distance that he walked. And that circle is where we were kind of getting concerned about that plateau in his progress. And you can see when we added in Exo, we only added it in once a week and the rest of his length of care. And the 3 additional weeks that he was there, he received Exo 1 time a week. And you can see that he had a kind of an additional jump in his distance that he ambulated, and he increased his FIM score 1 additional point. From a subjective perspective, there was you know, a significant improvement in his posture and his ability to maintain his weight positioning as he walked. So, I think in this case, I like it because, exoskeleton in terms for him was integrated actually later in his course of care. And so you can potentially see the benefit or the added benefit to having that integrated later. At the same token, perhaps he would have been even, it would have been even more beneficial for him if we added it earlier on, right? And prior to doing this case, I would have said there was no benefit for us to utilize an exoskeleton only one time a week. We just needed a significantly higher dosage. But I think this is a kind of a case example for me to show that, people that are this acute can benefit from even one time a week because it challenges them in a different way than what they receive in the treadmill or overground training. And so, yes, ideally, maybe he would have it would have been great to get him in more than once a week, but that was kind of our limitation at the time. And even once a week is beneficial, I think, in this case. So our second case example is kind of more of an outpatient case example. She's a 37-year-old female who's right-hand dominant, and she's about 2.5 years post a hemorrhagic stroke, and she has residual dominant side impairments. And her current ambulation ability is she uses an off-the-shelf kind of soft ankle brace and custom orthotics and no brace. And really her goal is to improve her ankle strength and mobility. And ultimately, she was a runner pre-stroke and would love to be able to return to that level of activity. So if we look at her walking here, you can obviously, she's not wearing her ankle brace here, which is not the typical way that she ambulates in the community, but she will walk like this at home. She definitely has decreased push-off at terminal stance, swing phase, clearance issues with compensatory kind of this knee whip going on, decreased heel strike, and some spatial temporal deficits with kind of a mild asymmetry in step length and also stance time. Her walking speed at baseline here is around 0.9 meters per second, just under. And really, if she walks for a longer time or at faster speeds, she actually gets pain at her lateral knee. And you probably can see it, right? I mean, she just kind of whips around there to get her leg through. And I think for this case, she's a little bit, in contrast to the other case, we can be a little bit more picky with the deficits that we're looking at. And so the objectives, I think we can kind of zone in a little bit more. And really we're looking at improving her kinematics and decreasing her compensation. And as a result of that, our goal would be to improve her pain, right? Get rid of her pain, as well as ultimately improving her walking speed. And if we can get her back to running, that would be great, right? And so if we really think about the impairments above here, we're definitely more looking at a smaller region that is impaired, right? So we don't need to put her in a bulky 2-joint device. We can really, and she's got function. So we really need more of an augmentative device at this point. And if we think about that, I think the Rewalk Restore is kind of a really great option for her. She's got some dorsiflexion and some plantar flexion ability, and we just got to kind of enhance it for her. How does she need to use it a little better? And so I chose to use Rewalk Restore, which is the device that assists plantar flexion and dorsiflexion dynamically. And it also allowed us to train without her ankle brace, which is something we couldn't have done without this type of device. And so this is her very, very early on in her training sessions. And I would say we're probably not even in her target intensity zone, but this is her calculated intensity zone of 145 to 164 beats a minute. And really, she didn't like to stand on her right leg and use the plantar flexion force. So we had to have her cue her to say, hey, take a longer step on your left side, to be able for her to use the plantar flexion force, because she just wasn't using it naturally. And as she started to, and actually started to use the device and use the assistance, the intensity started to ramp up quite a bit. And so the speed started to increase, whether it be on the treadmill or over ground. The device actually gives feedback about the stance symmetry. And so we were giving feedback to her during the session of, you're at 46, 53, 46, that type of thing, in order for her to improve her symmetry. So this is she was wearing a heart rate monitor throughout her sessions. And so because we were training at that higher intensity, it's not feasible for her to kind of just do this the whole session, right? So we had to do intervals where she would train hard, take a rest, train hard, kind of that high intensity training model. And so she would train hard, take a seated rest, train hard, take a seated rest. And you can kind of see that highlighted here. I don't know if you can see my cursor, but you can see her heart rate actually gets quite above this box, which is the box of her 70 to 85% of her heart rate max. So she actually has exercise-induced tachycardia. And so her early bouts don't get there, and then her later bouts are actually quite above it. So her max heart rate is probably around 184, 85 here in these bouts. And that's pretty much her max. She can't speak at that point, and she is working very hard. And if you look at a cumulative thing for this session, her mean heart rate was 137. That includes the rest breaks. I mean, definitely a productive session here in terms of getting the cardiovascular benefit that we're looking for. So from an objective perspective, and I think this is interesting, she was fairly functional, you'd say, right? She's walking at 0.89 meters per second without her ankle brace from a self-selective velocity perspective. And fast, when you ask her to walk fast without her brace, she's at about 1.15. After 9 sessions of training, she was at 1.25, is that right? So she had an increase about 0.33. That's pretty incredible. Right, yeah. And even higher for the fast velocity, which if you think about our sessions, they were really targeted at fast velocity. So it was like a change of 0.66, I think, for the fast velocity, which, our sessions were all as fast as she could, do while also maintaining good kinematics. And you got a little bit higher at the end of 13 sessions. So 4 more sessions later, we saw even a little bit further of a boost in the fast velocity. So for her, I think it's really, I hope this example might illustrate how this type of device, like Rewalk, can facilitate increased not only dosage, but also intensity for a patient who still needs an ankle brace in the community, but take that away and she is challenged but it's also totally safe for her to use that device and challenge her in a totally new way. And it totally wouldn't have been feasible to get her to that intensity without the device. And I think too, I didn't show it here, but she had improved symmetry in terms of spatial temporal parameters. And something she said is, I'm able to walk around my house better without my ankle brace because my ankle is stronger. I'm more confident on it. And I think that's just really, really, it says something, right? She's doing more because her ankle's stronger. And I showed that she had improved walking speed. And I think the biggest thing here is she doesn't have knee pain with walking. So some of those funky knee mechanics that we were seeing with the whipping and the getting around was just gone. And so I think, we show here that you can integrate the CPG action statements of that moderate to high intensity gait training, and also using the exoskeleton to really facilitate addressing improving her movement quality while also getting high dosage and also decreasing her impairments. And I think that's kind of like a dichotomy in PT, is that you can't decrease impairments and really focus on movement quality while also still getting high intensity and dosage. And I think this is a potential avenue to actually achieve that successfully. So I really see exoskeletons as a tool in my toolbox of rehab intervention strategies, and really one that requires us to be really thoughtful and intentional in our utilization in our practice. Along with choosing to utilize these technologies, I think it really requires us to know the evidence, right? And be able to be thoughtful about how do we incorporate the best evidence principles while also being able to utilize the technology effectively for each patient. And I think if you are able to piece those together, you can really get some successful patient outcomes. And I think, one of the things is, I learn best by reflecting, and I won't say that I have always been successful in my patient utilization. And I think if you are not successful, don't use that as like, oh, I'm never going to use that again. I think that's the time to reflect and say, why didn't that work, or what case, how could I make that better for the next patient? And so I think, is it because I didn't know the technology well enough? Is it because I didn't match the technology to the patient's deficits well enough? Or, is it something else? And I think that's the way that we're going to move the utilization of these pieces of technology that can be really helpful and effective for our practice forward, and actually improve the outcomes versus just potential careless utilization and gray, muddy outcomes. And so I think that's the one thing is utilize it and be thoughtful, and also reflect, and don't be afraid to switch it up.
I love that. And I think that that perfectly shows us how to put that framework into practice. I think that was really, really helpful. You did a great job of showing us, like, no matter where you're at with treating patients, whether it's sort of like your first time working with robotics, you're considering getting robotics, or have been working with them for a while, like yourself, is just knowing that each time is a new patient, and just take your time and work through that framework, and, you should get some good outcomes. So it's exciting stuff. What's also exciting to see with that first case, that chart of the resumed progress after the initial plateau, it was just really exciting and cool to see as well. So we have a few questions for you, so we'll just jump right into that. So sure. This is sort of a general question, I guess. So when multiple deficits or objectives are present, and they often are, right, with patients, how do you personally prioritize or weigh out the different needs of one against the other?
Sure. Yeah, I think that's a great question. I think it depends, honestly. And I think, for the first case that we talked about, I think first addressing his difficulty with maintaining his weight shift and his postural control was kind of like the ultimate, like, we had to start addressing that first. Otherwise, I'm working harder as the therapist behind. And there's no reason for us to progress intensity and decrease resistance or assistance of the device. Otherwise, I'm just hanging on in the back, right? And I'm like working really hard. Right. You've got to have him figure it out before you start to drop things off. And so as he starts to do that, then you can start to think about decreasing the assistive devices and decreasing the motor assistance and increasing challenge. And so I think it just depends on the case and depends on their presentation pattern and how you can prioritize it. But if they have difficulty with weight positioning and balance control, that, I think, first of all, has to be addressed first. Otherwise, it's just going to be like a sweating session for you as a therapist behind there, because you're hanging on for dear life,
right?
Making sure they don't fall over, right?
Exactly.
Yeah.
Praying for some good gains while you're back there.
Yeah.
Absolutely. All right. And so for that second patient, the one who is looking to get back to running, So the Rewalk Restore is fairly new, as we all know. And so just to help people sort of like understand of, with all the tools that you do have in your toolbox, what exactly, can you just elaborate a little bit more your thought process regarding why you chose to use that particular device for that particular patient?
Yeah, sure. So, I think, her impairments are certainly more focused at the ankle. You could probably look up the chain and pick things out that she's got deficits up her chain, right? You could say there's deficits, she's got circumduction or other things going on. But, if we really focus in, a lot of her deficits are related to her ankle. She has decreased propulsion and decreased, ability, toe clearance and that type of thing. And so if we really think about that, if we put a device that helps or augments those functions, could we improve that? And so, I think Restore just really addresses right down where her impairments lie. And so the Restore device, I think, really maximizes someone's already capable functionality. And so, you have to have some function, right? You can't just have no function. But for her, she has some plantar flexion ability and some dorsiflexion ability. And so let's just teach her how to use it better, right? And how to time it better. And so that's why I think, it's kind of this augmentative device, is that like, hey, this is really when you should be pushing off, and I think that's something that for her, she has a bit of apraxia, is kind of like, oh, I didn't know that, I didn't know I was supposed to be pushing off back there, and it was something that, every session we would start and it would be like ugly, and then it would be like this light bulb clicks on and it would be like, that was so much better. And so I think that's kind of my thought process for using Rewalk Restore in that case, and for other patients similar to her.
Yeah, awesome. I love that you said maximizes someone's functional capability. I like that. That's a great quote there. All right, so talking about a little bit, we're going to shift to in treatment. You mentioned a little bit using feedback such as either verbal cues for a longer step length, or maybe some visual cues in terms of looking at, sort of that stance symmetry graph. Can you just talk a little bit more about your strategies for utilizing and also for weaning that type of feedback with your patients?
Sure, that's a great question. So I think it depends on the device you have and the type of feedback that the device can give you, right? Some devices will give you feedback immediately. Like, so if it requires the device to give more assistance than you've programmed in, it's going to be, hey, I had to give you more. So sometimes I'll use that in a challenging sense of like, hey, we're going to try and do a down and a back here and get less than this amount of those beeps, right? Mm-hmm. So use it as kind of like a challenging situation for the patient. I think in the Restore sense, that's giving the stance symmetry. I'll give them a goal perhaps at the start of an interval as they start to learn the device. So that's, early on, I would give them kind of feedback during their interval. Hey, you're at, 52:48 as we're kind of going through the interval. And, that's kind of that immediate feedback, right? That's early on in motor learning. They need to try and make changes early on. And then I think as we go on in training, providing more summative feedback. So asking the patient, how do you think that went, right? What do you think about that interval in terms of your symmetry? And then saying, okay, overall, your stance symmetry was, ranging between, 53 and 40 and 52% and, 47-48 kind of thing overall in the interval. And so if it doesn't match, or is it kind of off? And so kind of, tapering your feedback from immediate to kind of more of a summative thing to enhance that motor learning.
Cool. Yeah. And then also, like you even mentioned for yourself, incorporating that piece of reflection and sort of accountability and goal setting, just to increase that sort of like inherent motivation for them as well, rather than just continually giving that feedback. And that can potentially help with carryover too, right? Because if they're in that process and that practice of habit of analyzing, their own performance, that's when hopefully we can see them making the gains without us there, just trying to like put a little mini us on their shoulder that they can take home with them, right?
Certainly.
Cool. All right, so one last one. So obviously you've had some success with using these types of devices with patients. Do you tend to use the device sort of right up until discharge with them, or what are some ways that you think about weaning patients off of these devices prior to discharge from a bout of PT?
Yeah, so I think that depends. And again, it depends on the patient's functional level and which device you might be using in terms of how you may choose to progress or integrate carryover within a session.
Mm-hmm.
And so you might be able to taper down the assistance in terms of, and see if the patient is able to maintain stepping ability or maintain like a speed target that you're asking for. And if they're successful and safe, maybe you could even drop out assistance completely. So for like Rewalk Restore, could I still maintain the dorsiflexion assistance for the safety piece, but drop off plantar flexion assistance and see if they're able to still maintain that propulsion while maintaining the stance symmetry that we've been working on, and also a speed target. The other thing is sometimes in a session, and this is not necessarily preparing for discharge as much as like earlier on, to try and just like get the carryover, is I'll split a session. So I'll do 30 minutes of gait training in a device, and then I'll carry it and switch them out of the device to do overground, to just try and carry over what I've been talking about in the device to out of the device, and see if they're able to carry it over. And especially that's, for someone who needs a lot of help, if they need that, then perhaps I'm not able to drop them down that much in the device, and I'll see if I can get them out and carry what I've been talking about out of the device.
Awesome. Yeah, that makes a lot of sense. I mean, it all just comes down to analyzing each specific patient and what your goals are with that patient, and just letting the robotics augment the session rather than necessarily maybe like dictating it. But yeah, that makes a lot of sense. Well, all right. So Kristen, thank you so much for your time. It was great. We had a great time talking with you. And to our viewers, we hope you all tune in with us again next week. Have a great week, everybody.
Thanks so much.